Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, February 27th, 2023. Stephanie Melka joins me to talk about nights and weekends. How do I know if it's an emergency? In this podcast, we try to break down what kind of issues are ones that really need to be addressed overnight and on weekends, and which ones potentially don't. During the podcast, we give a few disclaimers, but I want to state them up front as well. This podcast is not meant to be authoritative or definitive. Each situation is unique, as is each person and each practice and their practice patterns. So always follow your doctor or midwife's advice, and if you aren't sure what to do, better be safe and call them than not. What we're trying to do is to give you a look behind the curtain into what we are thinking when we get certain calls and what symptoms concern us a lot, such that we almost always want people to call and potentially come in overnight. Either way, it's always great to talk to Melka. Next week, we start a new miniseries on GI issues. Reminder for all of you listening on Apple or Spotify, please, if you could rate us, maybe throw in some comments, that would be awesome, preferably with 5 stars. All right, thanks for listening. Have a great week. We'll see you next Monday. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Melka, welcome back to the podcast. It's been a while.
It's been way too long.
You've been dodging me. You're ditching, ducking, dodging, diving, and dodging. The 5 Ds. Well, it's great to see you back in the podcast studio. And, as you know, you're a popular person on this podcast. People tune in to hear what Melka has to say.
Excited.
You're high up on the rankings and best podcasts or most listened to podcasts of all time. So
Sweet.
Very good. So it's an interesting topic. We're basically talking about, hey, how do I know if this is an emergency? Should I be calling? Should I be going to the hospital? Should I wait till the next day? And people don't always know.
Yeah, very often I get a call at night. And, for us, when you call the office, there's this ominous message. If this is an extreme emergency and you need the doctor on call, and then I get a very confused patient. It's like, I'm so sorry. I didn't know if this was an emergency. I think I need to talk to somebody. So we wanted to do this to try and clear things up a little bit.
Yeah. And obviously some of this is going to be unique to how we practice, but obviously most of our listeners are not in our practice and it's different everywhere. And so what we say may not be sort of accurate for your own practice or your doctor or midwife or whoever. So, we'll talk about that in our disclaimer section, that this doesn't always apply to everyone. But just, again, this is sort of a thought process. I mean, in general, when you're pregnant, you have regularly scheduled visits every month, every week, every 2 weeks, whatever it is based on the circumstances. And that's obviously a time not only for us to evaluate you and the baby, but a time for you to come with your questions, right? So things, that you write down, you have a list, things you want to know. And that's sort of the best time for non-urgent questions that can wait, things that aren't relevant for another month or two or whatever it is. And then obviously if things come up, you could also have additional visits, right? Hey, something has been bothering me. It's not a big deal. Maybe I can come in this week, stuff like that. And so we're talking about something that is new and comes up and the office is closed, right? It's night, it's weekend, it's a holiday. So that's what we're talking about. And how does it work? I mean, I know how it works, but I'm asking you to explain to our listeners, how does it work in terms of someone being on call? What does that even mean?
So for our practice, we have one physician on call that handles all of the deliveries, rounding, seeing patients in the hospital, and then any emergencies or phone calls that come up.
Right. And that's sort of nights, weekends, and it's a rotating basis. And that's obviously a big job, right? I mean, you could have several people in labor and it could also be quiet. It could be Sunday and there's no one in labor and you've done all your rounds and you could be hanging out. And there's a few things that's important about that. First is that person is available, right? Their only job is to be on call, right? And to be available for emergencies. And again, in our field, that includes labor and delivery, which I wouldn't call an emergency, but it's something that needs attention, right away, obviously. And so that person is available. They're available nights, they're available weekends. We rotate it, they're off the next day so they can, if they're up all night, it's fine. But on the other hand, saying like, we're not like the Time Life operators are just sitting there with headphones waiting for phone calls. If there's nothing going on, we might be home sleeping, or we might be doing something, or might be eating, or
when you're on call, you don't sit with this podcast set up.
Yeah,
the headphones on and the microphone ready to call.
Right. And there are circumstances where, for example, the doctor on call is automatically physically in the hospital on the labor floor. That's not how we do it, but there are places where it's like that. And so, for example, like one practical difference is I always tell patients, like, if you think you're in labor, don't just show up to the labor floor because I might not be there, right? I might be there, right? And there's maybe even a good chance I'll be there, but I'm not definitively going to be there. So call. So A, we can decide if it's the right thing to do, but B, even if it's obvious it's the right thing to do, I can let them know and I can myself make my way in. Otherwise, that's in our practice, the time sort of deliveries get quote unquote missed, meaning someone delivers and we're not there, is usually we didn't know they were coming.
Yeah.
That's typically the circumstance. Okay, so some disclaimers about this podcast. This is not definitive. Like, we're not here to tell people what they absolutely must call for, absolutely must not call for. It's different for every person, it's different for every practice, it's different for every doctor, different for every midwife. So that's not the point of this, even for our own practice. These are just like general principles. I would hate for someone to hear this podcast and think like, oh, there's a rule that they said in one direction or another, because that's not the point. And everyone's practice is different. So, make sure to be clear with your own doctor, maybe like, how does it work? How do you cover nights and weekends? Are you physically there? Are you not physically there? Are there things you do want me to call for, don't want me to call for? And ultimately do what they say. All right, we're just a podcast. There is some disclaimer at the end of this podcast too, that this is not like meant to be definitive medical advice. We're here to talk. That's all. Okay. So what's a good example of a call that you got that probably could have waited till the next day, just so people get like context on this? You could either tell me typical ones or even if you have a funny one.
Medication refills on weekends are challenging, where you don't have a chart in front of you. You don't often know everything's electronic now. I can't easily log on to my app and see what medication you're on, what pharmacy it goes to, when were you last seen in the office. So it's hard when those come in.
Right.
I mean, people forget, all of a sudden it's Friday night and you realize, oh, I never got my refill. And medically, you can't always wait. It happens sometimes, but it's tough on the weekend when you're getting those.
Yeah, that's a tough one. That's a common one, I would say also. This is not in this practice. Back when I was a fellow and I was moonlighting, I remember 2 calls that were just brilliant. One, I got a call at about 1 or 2 in the morning. Back then we had pagers. I got a page. I got this, I got a phone number. I called back. Hi, Dr. Fox, Nate Fox, I'm on call. I can help you. And the person on the line said, great. I was just checking what the response time is.
Wow.
So I said,
bold move.
I said, how was my response time? They're like, very fast. I was like, can I go back to sleep now? They're like, yes. So I tried to hide my irritation. That was not cool. And the other one, I remember this vividly. I was at home on call. Actually, I guess it may have been for this practice. Very, very early. I got a page and someone said, I'm pregnant. I'm 20 weeks. I'm like, okay. She goes, I have a runny nose. It's like, 2 in the morning. I said, excuse me? She goes, my nose is running. What do you think I should do? So I said, have you tried tissues?
You did not.
I did. And she said, okay. And that was it. That was the call. It was just, I don't know. Maybe they were in a different time zone. I'm not sure. That's happened. People sometimes call from other countries when they're on vacation. Yes. Remember the time zone difference? We may not be on your time. I remember that was the Andre's like, he got a call and someone's like, this. And he's like, well, you should come to the hospital. She's like, I'm in Jerusalem. He's like, okay.
Go to the hospital there.
Yeah, we'll defer that. So those are the ones that maybe can wait. What about the opposite? Have there ever been times where someone the next day or whatever it is, like comes to the office, you're like, oh my God, I can't believe you didn't call overnight for this.
I've been leaking fluid for 2 days and it wasn't a big gush. So I didn't think it was my water that broke. So I've been waiting.
Yeah, that's one.
And then it sort of adds up over time. And then it's like 1, 2 a.m. They're awake and they're like, I don't know. It's just been going on so long.
Yeah. I've got the one where I would get like a text at like 6 a.m. from someone on my cell phone, like, hey, I've been bleeding all night. I'd be like, it's like near their due date. I was like, oh my God, please tell me you called the doctor on call. Like, no, I was waiting for you to wake up so I could text you. I was like, oh my God. Everything was okay. Thank God. No problem. Her and baby are fine, but that's not great. And it's not always intuitive. So we're here to help, right? So what are some like general rules of thumb? And we'll get into specific examples, but just sort of like general principles that people can maybe take away when considering whether they should be calling at night or on the weekend.
If you feel like you're sick and there's something wrong and you need to go to the hospital and see a doctor, you should call.
Yeah. And that's even if it's not pregnancy related.
Correct.
Right.
And it's hard to put strict rules on it. But when I break it down, I typically break it down to term or close to term and then first and second trimester.
Yeah. I mean, if someone is sick enough that they would normally go to a hospital or an urgent care or whatever they have locally, you should call. Because number one, we may be able to help you over the phone, right? Maybe it's not that bad and maybe we could sort that out. But number two, if it really is that bad, we need to know about it, right?
Mm-hmm.
Either we can direct you to the right place, or at least we can know what's going on, or if there's a question about what medication can you take or not take, or whatever it might be. And I usually tell people, like, when you're pregnant and you have a medical emergency, regardless of the emergency, we're your first call. If we're not your first call, we're your second call. Like, you have to call. Sort of like if you get arrested, you call your lawyer. Like if you're pregnant and there's something going on that you're about to head to a hospital, call your obstetrician. I mean, someone's like, I think I had food poisoning, I think I got appendicitis, I think I broke my leg, like whatever. I need to know. Like, call me. Even if I'm not the one who's going to be fixing your broken leg, I need to know that you might have one and you're pregnant. And so absolutely call your obstetrician for this. I think in general, if you think it's an emergency and it needs to be addressed before the office opens, call. Right? Anything that you think needs to be addressed before, whatever that is, 8 a.m., 9 a.m., 7 a.m. tomorrow, you should call. Or if you're not sure if it's an emergency, but you think your doctor thinks it's an emergency, also call, right? Because not everyone agrees with what their doctor or midwife thinks is an emergency. But if you think your doctor or midwife thinks it's an emergency, please call.
I get that sometimes.
Yeah.
I didn't want to call because I knew you'd tell me to go in and I don't want to go in, and then they tell me whatever it is. And I'm like, you know what I'm going to say? Like, yes, your baby's not moving normally the way it was. Of course you have to go in.
Right.
I'm sure you think it's fine and I'm sure it's going to be fine. But if you know I'm going to tell you to go in, then call and go in.
Right. And we don't have an automatic response at any phone call that comes in. We tell them to go to the hospital. Frequently, we tell them not to. Like, oh, that's normal. That's this. Try this. Wait an hour. Do this. Like, there's a lot of things we can do to help sort of triage whether you need to come into the hospital or, do you have to be in the office first thing in the morning or do you not? And so a phone call to us does not always mean, oh, I'm heading to the hospital.
Right.
We could, we want to know what's going on. If you're worried enough to think it's emergency. On the flip side, if you're highly confident this does not need to be addressed until the next day, then you don't need to call. You can just call the next morning. I mean, some practices would rather you call at a certain time so we can get you on the schedule. And that's unique to each practice. But essentially, if you're highly confident, like, medication refill, I don't have to have this overnight. It's not an emergency. Fine, we'll do it tomorrow. Call the office and someone will pick up and take care of it for you. Now, what if someone doesn't know? Right? Well, I have something and I don't know if it's an emergency, which is tough. You don't always know. What would you advise that person?
I generally advise call.
Yeah,
some of it is a liability thing.
Yeah.
I don't want somebody sitting on a concerning symptom for longer than they should.
Yeah.
Because they felt bad about calling.
Yeah. Yeah. I tell people the same. I say, listen, like the person involved, this is what we do. This is our job, not in a bad way. This is why we're here. And so if you're not sure, I'd much rather you call and I tell you either, no, that's not a problem, you're fine, or yes, that's a problem, let's do A, B, and C. I'd rather just know about it early. And it's not embarrassing. And we don't get upset if you say, hey, this is going on. I don't know if this is an emergency. We can usually sort that out in 20 seconds. I mean, it doesn't take too long. And we'd much rather know because there's several times where there is something going on. And for the times that it's not, fine, you're reassured, you go to sleep, you're okay. And you know that we can deal with this whenever it might be. The only thing I would say is if you're in that sort of, I don't know what to do situation, make that decision early. Yeah. So don't waffle until like 3 a.m. and say, all right, now I'm going to call, right? If you knew that this was going on at 7, 8, 9 at night, generally better time to, hash that out with the doctor on call than at 3 a.m. That's just a public service announcement, for your friendly doctor on call. But again, really, I tell people, if you don't know whether to call, just call. This is what we do. These are the calls we take. Like, this is fine. This is all good. It helps us understand what's happening and it's part of good care and it's our pleasure. Like, that's why we're doing what we do. And particularly if we know that the person calling is sincere, like I'm worried. I don't know if I should be worried. Great. Like, let me help you. And that's usually very easy. That is the overarching principles and our disclaimers. Let's get specific. So I thought we'd break this down, like you said, sort of by stage of pregnancy. So let's talk about early pregnancy, right? So either someone is pregnant and they haven't seen us in the office yet, or they've been to the office, but it's still like first trimester stuff. What are the typical things that are related to pregnancy? Obviously, someone could have pneumonia at any time in their life or whatever, but related to pregnancy, what are the phone calls that typically would be emergent on nights and weekends or first trimester stuff?
Typically bleeding, pain, nausea, vomiting.
Yeah.
I think that's all of the first trimester calls.
Probably in that order. Yes. So, bleeding's an interesting one for, because it can be a significant emergency and it can be nothing. And everything in between, which is tough. I think the rule of thumb is if you're bleeding, the default is you should call. But the caveat to that is on our end, when we get that call, which bleeding phone calls are you going to say, I need to see you ASAP?
Anyone bleeding heavily where like hemorrhaging. You know, what I personally use for patients is soaking through 2 thick pads in an hour, like really soaking through pads. Like, I think you should come in.
Right.
If it's a miscarriage in process, there's nothing to do about it.
Right.
But you might need an emergent D&C if things don't pass. If it's somebody very early, like 5-6 weeks, and they're miscarrying at home, I think you can sometimes talk them through and have them stay at home. Right. But it's hard if someone calls you with that level of bleeding.
Yeah.
You have to sit, you should be seen for that.
Yeah. I mean, that's true. Bleeding from any part of your body at that volume is typically an emergency. I think one of the other hard things is the one sort of bleeding complication that we get really worried about is if they have an ectopic pregnancy. And so if once we've seen you in the office and you have an ultrasound and the pregnancy's in the uterus, it's not an ectopic, or highly confident it's not an ectopic. And so that sort of like lowers the level of risk significantly in whatever kind of bleeding call is going to come in. But if someone hasn't been in yet, or they came in and they're sort of one of these people that's on watch for a possible ectopic, that's someone we're going to bring in earlier, because bleeding, especially if it comes along with severe pain in the belly, is going to be much more concerning to us about a possible ectopic. So again, if it's early pregnancy and you haven't been seen yet and there's bleeding along with pain, that's generally something we're going to want to check out either right away overnight, or, hey, we need you in the office first thing in the morning. Based on what time it is and sort of what resources are available in your office versus do you do your ultrasounds in your office, you send them to the emergency room, send them to the hospital. There's a lot of variation in these things, but that generally needs to be evaluated pretty quickly, even if not like immediately. And then the bleeding, again, it's usually, people call for bleeding, they tell them to call for bleeding, and that is the correct thing to do. But typically, if it's a very light amount of bleeding that's not itself dangerous, and we're pretty confident it's not an ectopic, there's not much we can do if we see you. Sometimes we can give some reassurance, do an ultrasound, show there's a heartbeat, but to go to an emergency room to do that is fine, but it's a lot of weight, sometimes a lot of cost, sometimes a lot of frustration, whereas coming to the office and getting it done there, if it's available in your office, is usually just easier for you, the patients. For us, they go to the emergency room, it's not hard on us. It's, emergency room staff. But again, it's tough. So bleeding, typically people call, but we frequently will not bring them in overnight or on the weekend unless we really had to. Yeah. And then
the emergency room is very good for emergencies.
Yeah.
But it's a tough place to be.
Yeah.
Like, very crowded. There's a long wait. You're often in a stretcher next to other people, or you have a curtain.
Yeah.
And to be diagnosed with a miscarriage or a possible miscarriage, like it's hard for women. It's hard for people to go through that.
Yeah. Yeah. And some of this is also, again, resources. Some practices, say some solo gynecologists, they might not have 24/7 coverage. And for them, it's ER or nothing. Yeah. And okay, if that's the option, then you have to make a decision. Do I want to go to the ER or not? And again, hopefully someone can guide you what to do, but depends, again, what's available and what the options are and how soon could you be seen.
Yeah. Sometimes I actually ask patients, like, do you think you need to go to an emergency room for this?
Right.
And it sounds kind of silly, but I think it can help patients see the perspective of like, do I need to be seen immediately at 3 a.m. for this, or do I think I can wait till 8 a.m.?
Yeah, exactly. And again, also sometimes this changes, whether it's Friday at 5 p.m. when the office opens, Tuesday after a long weekend versus Sunday night, Monday morning at 4 a.m. when the office opens in 3 hours. Yeah. All right. So there's going to be some differences based on that. Nausea, vomiting is something people actually, I probably added to the list of things people don't call about, but they should. Someone's like, oh, I'm pregnant, I'm supposed to be this sick, but they haven't eaten in 2 days. They're passing out. They're like dizzy and weak, completely dehydrated. And they're like, well, no, this is normal. No, that's not good. Like it's something that really can hopefully be addressed. And I would consider that an emergency, even if It's not something we can necessarily cure. We could potentially improve and help people with. And also a lot of times people, it's not just nights and weekends. They're sort of like, well, I got to wait till my first visit in 3 weeks. I got a phone call from a friend recently who was telling me, I assume it's their daughter. They were kind of anonymous about this. Well, someone I know is early pregnancy and is very, very sick. She hasn't eaten in 2 days. She's, really weak.
Yeah.
She's throwing up 12 times a day and this. And she goes, what medication should I get for it? And I was like, well, there's A, B, and C. I said, but has she seen her doctor yet? And she goes, well, no, she's like only 6 or 7 weeks. Her first visit isn't for 3 or 4 weeks. I said, have you even called them? She's like, well, no. I was like, call. Like, they should see her today, tomorrow. Like, they need to see her and see what's going on. We don't typically see people that early, but if someone's not well, of course they should be seen earlier. And listen, this person, she's a doctor. She just had no idea that that's even like done in OB circles. And so it's something that is another one. Severe. I mean, if you're a little bit nauseous, you can call and usually they'll give you a prescription even without seeing you. But if you're severely sick, you need to be seen. All right. So now let's move on to the middle of pregnancy. So second trimester, third trimester, not quite in the full term period. Calls are kind of all over the place here in terms of what, there could be bleeding, there could be pain, things that, is this labor? Is this preterm labor? Am I feeling the baby moving, not feeling the baby? Like, there's a lot of stuff sort of like overlap from the first trimester leading to the end. But basically, how do you address those calls? Or what are the things that are really emergencies to you in the middle of pregnancy?
I mean, similar things. Pain and bleeding. You start getting into questions of fetal movement.
Yeah.
Where you might not feel movement till 20, 22 weeks.
Yeah.
You might go a day that you only feel one movement. You might have a day you feel more, a day you feel less. And so you'll get some calls about that as well.
Yeah. I mean, fetal movement is something that generally before like 23, 24 weeks, we're not so focused on it in that sense because it's not everyone has the baby moving or feels the baby moving. The babies are moving, but they're not generally felt until that point. Sadly, there's not much you could do if the baby's not moving well that early. Again, it's very rare when that happens. And so usually someone calls in the second trimester with issues about the baby moving. We just reassure them and say, hey, come into the office tomorrow, this week, just so we can show you everything's okay. Just a peace of mind, not so much as they need to do. In the third trimester, it's a big deal. Like we take that very seriously. And so that's something we need to know about. So let's talk about that. So let's talk about fetal movement. Someone calls in the third trimester, the 30 weeks, right? So it's not full term, but they normally feel the baby moving every day. And they say, hey, I just realized, I got home from work and I started paying attention and now it's like 8, 9 at night. It's been 3, 4 hours. I haven't felt the baby move at all. How do you address that?
I have a very low threshold for bringing people in for this.
Yeah.
The compromise to sort of try to get somebody to induce movement is drink something cold and sweet like juice, eat a little piece of chocolate, make sure you're sitting in a quiet room, hands on the belly, like paying attention to movement. But if it's really like it's been all day and I've felt nothing, you got to go in.
Yeah, I do the same. I almost always give them the same, like, lie down, close your eyes, focus on the baby. If you feel 2 or 3 movements in a half hour, everything's okay, you're good. And if you truly don't, we should see you. Yeah. And that means come in. And I tell people 99% of the time it's going to be fine. And we know it's going to be fine, but we need to know because it might not be.
And
right?
I'd rather have 99% of those women come in and schlep to the hospital and be seen and be sent home than have one person not come in when she should have.
Yeah. And so that's agreed. This is it's considered an obstetrical emergency if you don't feel the baby moving. Again, with usual understanding, the babies don't move continuously. And if you're very early, you don't always feel it. But in that point, like when you're already feeling the baby move every day, when there's a significant change and you can't feel the baby moving despite sort of the tricks we're talking about, definitely call and we're bringing them in. And that's something, even if we're not there, like I could be at home, go now, just go there, get the baby in the monitor, make sure everything's okay. And you may even go home and I won't even see you. Like I'll just get on the phone, say, you're fine, you're good, baby looks great, go home. So that is definitely one. And that's true pretty much full term as well. I think that in that middle of pregnancy, like 20 to 36 weeks or whatever it is, there's also a lot of stuff like, is this a sign of preterm labor? Or like I said, pain, I'm having some contractions, I'm having some cramping, having some pressure. How would someone know, again, whether that's something they need to call about at night versus wait till their next visit versus call the next day? Because that's a wide range also.
Anything really severe, like you're doubled over in pain, you can't sleep, you should go in for.
Yeah.
What I'll tell people is you get more uncomfortable at the end of the day. You get more uncomfortable if you're a little dehydrated. So if you're cramping, hydrate, sit, try to sleep. If you fall asleep, you're not going to wake up with a baby in the bed because you slept through contractions.
Right.
Like if you can fall asleep, that's a good sign that this isn't an emergency. But hydrate, try and rest. If the pain is keeping you up, call me back. We'll send you in.
Yeah. And this isn't a perfect rule either, because again, if you're concerned that you're having preterm labor, just call and, we can talk you through it on the phone and decide.
I'll happily send someone in. If they call and they're worried, I'm never going to refuse to send someone. You can go in and get checked. It's more trying to be kind to the patient, not send them in just because they called.
Yeah. I mean, I generally, people do get contractions in the second and third trimester, as long as they're sort of sporadic, not particularly painful. They come and they go, here and there, they go away with rest. Then that's not something that's going to be preterm labor. But generally, if they're getting closer together, they're getting stronger, they're not going away.
If you're having bleeding.
Certainly with bleeding. Then we're going to send you in. And so again, it's one of these things where if you're not really sure, just call. And that's a very easy phone call. We'll ask you 4 questions and we'll know right away whether you need to come in now or whether it's okay to wait and see how it goes.
And I'd be more likely to send someone in that's at higher risk for preterm.
Sure. So
twins, collage, prior preterm birth, any of that, you know, more likely to go in.
Yeah, absolutely. Definitely. Because again, the chance that it's real is just going to be higher. And also same thing, like where do they live? All these things, like how long did it take you to get here? Again, these are questions we just like boom, boom, boom. It's not going to take very long to us to figure this out. And this is definitely one of those better safe than sorry phone calls, because the last thing you want to do is, I've been contracting all night and then you wait till the morning. That's just not, and also people are worried about it. They don't need to be sitting worried. That's not necessary. Another thing is, what if someone thinks their water may have broken?
That's a tricky one. Most of the time people know for sure.
Yeah, it's obvious.
It's obvious. We send them in. We actively manage our PROM, our ruptured membranes before labor. If they're not sure, I'll usually tell them, put on a clean pad, walk around for a few minutes. If there's more fluid leaking out, go in.
Yeah.
But if not, it was probably just discharge or a little bit of urine that came out.
Yeah.
So that I'm more comfortable with somebody staying home.
Yeah. I mean, I would say at any point in pregnancy, if you think your water broke, call.
Yeah.
Like the call, definitely. And that is 24/7, right? If you think your water is broken, you should call. Now, when we pick up the phone, 9 out of 10 times it's obvious your water is broken, and we'll tell you what to do. Again, if you're preterm, we're going to send you to the hospital right away. If you're full term, we are going to send you to the hospital, not as emergently, like we'd say, if the baby's moving, you can take a shower, get your stuff. But basically, we're going to be sending you in. But there are times when it's not so clear. Like you said, like, I'm not sure, maybe it is, maybe it isn't. And then that's a situation where, based on the circumstance, we'll either bring you in right away to evaluate, like if you're very preterm, or maybe do some things at home to sort of figure out what to do. We're more likely to do those, obviously, someone who's full term, because the stakes aren't so high necessarily for waiting. But if you think your water's broken, definitely call.
And also somebody who lives an hour and a half away, has had 5 babies and always delivers fast.
Yeah.
I'm going to say, I think you should come in.
Yeah.
Like, get in the car, start making your way in.
Yeah.
Like, I'd rather you have the false alarm by coming in and it's nothing than staying home and waiting too long.
Exactly. And, at term, it's the same calls. Almost always it's contractions, water breaking, baby not moving, or bleeding. Like those are the big 4. And we want to know about all 4 of those at full term. Again, at night, a few contractions where it's pretty obvious you're not in labor, you're welcome to call, but no one's going to send you in. If you're, at your due date and you're having a contraction every 15 minutes, like that's nice to know, but you're not in labor yet. And so I would say, you could probably wait and see what happens. So
Same thing with light spotting.
Yeah.
Like a little bit of light spotting at term, like you can give it time.
Especially if you're in the office that day and they examine you, or it's like expected to get some spotting. And so again, like I tell people, you're welcome to call, like it's no problem, but the chance I'm going to send you to the hospital for a contraction 4 times an hour at your due date, unless something else is going on, is very, very low. Unless maybe they were 5 centimeters dilated in the office that day and they live 2 hours away. All right, sure. Then that person, fine. But again, it's one of these things where the things that are more concerning, like babies not moving or significant bleeding, we'd want to know right away. And water breaking, we're going to want to know, but based on how obvious it is and what's going on, how soon we're going to need you to act. And contractions are the same way. What about people who've already delivered and gone home? Sometimes they forget that we're still their doctors. Like, hey, just because you're not pregnant, we're still here to take care of you. I mean, certainly through the postpartum visit and, beyond if we're your gynecologist as well.
Yeah.
And so what are the types of things that people should probably remember to call for at nights or weekends if they're postpartum?
Generally, again, severe, heavy bleeding, pain, severe, not improved with pain medication.
Yeah.
And fevers.
Yeah.
I throw fevers in there.
Yeah, we need to know about those. If you wake up at 5 a.m. with the fever, could you wait till 7 or 8 to call? Yeah, probably, but whatever. I mean, fine. It called 5 also. but that's something we're going to want to see. That's pretty important. Preeclampsia is a condition that can happen after delivery when you go home and it's real and it's a problem. It's hard though, because there aren't really great symptoms to pick it up or to rule it out. And so things like headaches that are new, we want to know about. Again, doesn't mean it's preeclampsia. Sometimes it's just not sleeping from having a newborn. Sometimes it's related to the epidural. Sometimes it's preeclampsia. But that's something we're going to want to know about, particularly if it's getting worse and worse. Just call. Like, it's okay. Like, that's something we want to know about. That's another one. Also, certain things like new symptoms, like I'm severely short of breath when I wasn't earlier today or wasn't before. Like, sometimes complications happen that are rare and people forget, like, we need to know we're still your doctor. We'll make sure everything's okay. And again, if we get the call and say, it doesn't sound like much, but we'll see you in the office tomorrow just to be sure, versus, this seems pretty serious. Maybe you should come in. And it's a big deal to get called back into the hospital after you deliver, because frequently that's not with your baby. Sometimes it is. Again, depends on the hospital, depends on all the various circumstances, but it could be you're not with your baby. And it could be if you are with your baby, that's a big, how does that work? Yeah. Right. And then you're nursing, like, it's a thing. And we know that. But if we're going to send you in, it's going to be for a real reason, which means we really need to see what's going on. Yeah. Yeah. Wow. I think we covered it.
I think we did.
Nights and weekends. I was going to title this podcast, Call Me Maybe, but I didn't want to give people the negative connotation, that we're trying to tell people not to call us. So I don't think we're going to use that. We'll pick another snappy title to the podcast that is worthy of us as play on words type of people. I know. I see the wheels. The wheels are turning in Melka's brain for all the various, I
had something, but it's not appropriate. It would get censored.
Got it. Check. Fair. All right, Melka. Thanks for coming on. Thanks for talking about this. Appreciate it. All right, we'll see you again. Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.